A very good morning to all. We are from Group 1 and for today, we're going to be presenting on Case 1 of the red blood cell light microscopy practical. Before we start our presentation, here's a list of our group members' names and their respective matrix numbers. Alright, let's first take a look at our case. I'm just going to read it out. A 48-year-old man with chronic renal failure was referred for evaluation of a worsening anemia. He reports to have a long-standing history of general fatigue and poor exercise tolerance, which he feels have worsened of late. Upon physical examination, he was pale with no jaundice. Other than that, there weren't any significant physical findings. On the right-hand side, we can see the complete blood count of the patient. You can have a glance through it, as we are going to be using this result later on in the questions.
First, what is the significance of chronic renal failure and his anemia? To start off, we need to know that a healthy kidney will produce hormone called erythropoietin, EPO. EPO prompts the bone marrow to make red blood cells, and these red blood cells circulating throughout our body by helping to carry oxygen. Thus, when someone has chronic renal failure, their kidney is damaged and fail to produce enough EPO. There is low erythropoietin in their body and cause bone marrow to make fewer red blood cells. This leads to anemia.
What is the significance of poor exercise tolerance? Poor exercise tolerance is a condition of decreased ability to perform physical exercise at normal capacity. So this person will easily experience severe post-exercise pain, fatigue, muscle cramp, and nausea after doing the exercise. Since this man has anemia, the possible causes for having poor exercise tolerance is mainly because of decrease in oxygen uptake. When hemoglobin level is low, it will cause oxygen carrying capacity to be low as well. So, red blood cell will carry less oxygen to the skeletal muscle, and skeletal muscle will receive insufficient oxygen that doesn't meet body's need for the exercise. Another possible reason for having poor exercise tolerance is iron deficiency. When having iron deficiency, it will reduce oxygen transfer capacity, which is hemoglobin, since iron is one of the components of hemoglobin. It will cause decrease in oxygen uptake.
Let's proceed with the pathophysiology of renal anemia. Here we're going to discuss about the possible factors of anemia in chronic renal disease. The first one is inadequate production of erythropoietin, and the second one is iron deficiency, and also we will be discussing the other factors that cause anemia in chronic renal disease. The main one is inadequate EPO production. As we all know that the healthy kidneys produce a hormone called erythropoietin. EPO binds to the EPO receptor expressed on erythroid progenitor cell, inhibiting apoptosis and enhance circulating red blood cell production. But when the kidney's function declines due to the disease, they do not make enough EPO, which results in the bone marrow to make fewer red blood cells, causing anemia. We'll be talking about iron deficiency. Absolute iron deficiency occurs due to a combination of tendency to poor dietary iron intake when uremia causes anorexia, impaired iron absorption due to elevated hepcidin level. It is produced by the liver in response to a number of factors including body iron status and inflammatory cytokines, and bind to ferroportin on the basolateral surface of gut enterocytes, therefore inhibiting absorption of iron from the gut lumen. These factors therefore contribute to increased hepcidin level in chronic renal disease, which in return leads to reduced iron absorption. And the last one is gastrointestinal bleeding, which is caused by gastrointestinal lesions such as mucosal angiodysplasia and uremic platelet dysfunction. Next, Functional iron deficiency refers to the observation that the patients usually will have anemia with exogenous iron administration when the conventional measures of iron stores such as serum ferritin, transferrin saturation, and bone marrow iron staining are normal. This is primarily caused by the elevated level of hepcidin level, which eliminates non-transferrin bound iron from the circulation by trapping of iron in macrophages. The effect of trapping iron in macrophages deny pathogenic bacteria access to iron essential for proliferation. And the other factors to consider are also secondary hypoparathyroidism, shortened circulating red blood cell survival, vitamin B12 and folate deficiency, medicines that suppress EPO production, and intradialytic hemolysis.
So now I will talk about the complete blood count CBC, which is also known as full blood count of first case study patient. So this is the result of the complete blood count of the 48 years old man who having a chronic renal failure. So from this test, we can know about the level of the white blood cell, red blood cell, hemoglobin, hematocrit, the MCV level, MCH, and the level of the platelet, and also the level of the reticulocyte. So the question is asking about three important findings on this 48 years old man complete blood count. So what we can see, the first important finding is the hemoglobin level. The hemoglobin level is low, which is only 3.4. And then the second important finding on this 48 years old patient is the MCV level is only at the 4.4 femoliter, which fall under the normocytic. And the third important finding is about the level of reticulocyte is low, which is only 0.02%.
The morphological classification of the patient's anemia is severe normocytic normochromic anemia. This is shown by the full blood count result in which the hemoglobin level is lower than 7 grams per deciliter, but the mean cell hemoglobin MCH is still within the standard range. Other than that, the mean cell volume MCV is 84.4 femtoliters, which is also within the standard range. Hence, the patient's morphological classification of anemia is severe normocytic normochromic anemia.
Let's move on to the further investigation test in relation to this case. In addition of complete blood count tests, we also can conduct several tests to ensure the form of this case. First of all, the test that can be used is blood smear or peripheral blood film test. Basically, this test requires simple technique and equipment which is glass-like and of course a functional microscope. Unlike the complete blood count, we will look at a blood smear under the microscope in order to detect a wide range of changes that give clues to underlying disease. The expected findings that can be obtained from this case are the size and shape of the cell is within the normal range but low in number. Next, we have iron serum test. The reason why we can conduct this investigation is in order to observe or evaluate abnormalities of iron and the causes of anemia. The findings for this test are the iron serum level is low, the transferrin saturation is low, and last but not least, the total iron binding capacity or TIBC is high. It is due to the lack of iron in blood. Therefore, the chance of blood to attach to the iron became high. Here is the example of observation of blood smear test taken from the patient with normocytic anemia. As you can see, the hemoglobin size is normal but low in number. Next, this is the table of the iron blood test result which we can compare between the normal person and normocytic anemia patient. As I said earlier, the person with normocytic anemia have low level of iron serum and transferrin saturation compared to the normal one. In contrast,
The total iron binding capacity or TIBC of normocytic anemia is much more higher than the normal person. You must be wondering, do we need to conduct the bone marrow investigation? The answer is no, because based on the complete blood count and the patient history, we can see that the amount of reticulocyte is lower than the normal range, and it is due to the renal failure. Unless the patient not having any chronic disease, we can assume that the patient have a problems with bone marrow, and then we can pursue to do the bone marrow investigation.
Describe the pathophysiological and relate the morphologic alteration of RBC that you expected to see in his blood smear. As stated in patient's history, he is having chronic renal failure, which indicate the kidney failed to function normally. This could affect the production of EPO, erythropoietin, which is the hormone that stimulates red blood cell production. Therefore, there will be reduced rate of production of red blood cell in the blood. As a result, normal size but low count of red blood cell can be observed through the blood smear test.
Alright, time for a quick summary. Since we know that the patient has chronic renal failure and we know that the function of kidney is to produce erythropoietin that stimulates erythropoiesis, which is the production of red blood cell, when one has something wrong with the kidney, we might expect the erythropoietin level to drop, and thus the rate of erythropoiesis will drop as well. And this is evident based on our full blood count that shows a low hemoglobin level and a low reticulocyte count. A low hemoglobin level also leads to the typical anemia signs and symptoms like poor exercise tolerance, pallor and fatigue as reported by the patient and examined by the physician. Another interesting thing to note is that since this is a chronic disease after all, we might tend to associate it with anemia of chronic disease. This leads to the question of whether iron is one of the contributing factor in this anemia. However, based on our full blood count, it seems that the mean corpuscular hemoglobin is quite normal, and thus this anemia is normochromic, and we cannot yet associate this iron deficiency with this case directly. And this is why we ordered other tests such as the blood smear test and serum iron test in order to confirm the case. One last thing to note is that we categorize this anemia as severe normocytic normochromic anemia because the MCV, the mean corpuscular volume, falls between 80 to 100 femtoliter, which falls under the classification of normocytic. And that's all from us. Thank you.